Hello, and welcome to CRPS Contender, my complex regional pain syndrome education channel. Today we are taking another step down our journal journey of When CRPS Spreads, exploring the paper Spreading of Complex Regional Pain Syndrome, Not a Random Process. This paper was published in February 18, 2011 in the Journal of Neurotransmission by Rijn et al. Sorry if I pronounced your name wrong, I really like your work. Let's take an excerpt from their abstract. CRPS generally remains restricted to one limb, but occasionally may spread to other limbs. Knowledge of the spreading pattern of CRPS may lead to hypotheses about the underlying mechanisms, but to date little is known about this process. The objective is to study patterns of spread of CRPS from a first to a second limb, and the factors associated with this process. 185 CRPS patients were retrospectively evaluated. 89 patients exhibited CRPS in multiple limbs. The hazard of spread of CRPS increased with the number of limbs affected. Compared to patients with CRPS in one limb, patients with CRPS in multiple limbs, on average, were 7 years younger and more often had movement disorders. Spread is associated with a younger age at onset and a more severely affected phenotype. We argue that processes in the spinal cord as well as supraspinal changes are responsible for spontaneous spread in CRPS. Look at the introduction. CRPS is characterized by various combinations of sensory, autonomic, and motor disturbances, and is usually preceded by a minor to severe physical trauma affecting that limb. CRPS usually remains restricted to one limb, but it can spread to other body parts, and may do so more often than one might think. CRPS in one limb may extend to another limb, either as the result of a new trauma to a previously unaffected limb, or because the syndrome spreads spontaneously. Although different causes of spontaneous spread have been proposed, the underlying mechanisms have not yet been determined. As a tertiary care center for CRPS, the authors were able to characterize a large sample of patients with spread. If systemic factors underpin spontaneous spread, one would expect an indiscriminate pattern of spread. If cortical mechanisms underpin spontaneous spread, one would expect an ipsilateral or same side of the body pattern of spread, and if spinal mechanisms underpin spontaneous spread, one would expect a contralateral pattern, or to the opposite side of the body. All patients who visited the outpatient movement disorder clinic of the Department of Neurology of the Leiden University Medical Clinic from January 1998 to April 2004 were considered for inclusion in the study. Patients were eligible if they met the CRPS criteria of the International Association of the Study of Pain, either at the time of disease onset or at the time of presentation at the clinic. Although only criteria 2 to 4 have to be satisfied, the authors only included patients who identified an initiating noxus event for the first affected limb. Patients with simultaneous onset of symptoms in more than one limb, or with simultaneous spread from one affected limb to more than one subsequent limb, were excluded from this analysis. The hazard of spread was estimated, while several variables were accounted for, including trauma characteristics, location of initial symptoms, presence of movement disorders, and patient characteristics. Moving on to data collection. Dates of onset of CRPS signs or symptoms for every involved limb were obtained from the patient's history. Medical records were reviewed to verify data wherever possible. Sensory features that were recorded included pain, hypoalgesia, hyperalgesia, and allodynia. Recorded autonomic features included edema, temperature changes, color changes, and hyper or hypohidrosis, as well as changes in hair and nail growth. Recorded movements disordered included dystonia, tremors, and myoclonus. The authors did not consider muscle weakness as a movement disorder, as this could result from either pain or edema. The age at onset of the first limb and the length of interval to the onset of symptoms in subsequent limbs were also calculated, as well as the presence and type of trauma, such as soft tissue injury, fracture, or surgery, preceding CRPS, were registered. Data collection. First, if CRPS was present in only one limb, patients were categorized as Single-CRPS. If CRPS was present in more than one limb, they were categorized as Multiple-CRPS. Second, Multiple-CRPS cases were categorized according to whether the spread was associated with separate trauma to the limb or not. If not, patients were categorized as spontaneous spread. If so, they were categorized as separate trauma. Third, Multiple-CRPS cases were categorized according to which limb was subsequently affected. Contralateral, such as the left hand to the right hand. Ipsilateral, left hand to the left leg. or diagonal, left hand to right leg. This resulted in 185 patients who were included in the study. During the assessment, 96 patients had a single affected limb, which was 52%, and 89 patients had multiple affected limbs, which was 48%. See, the numbers were higher than you might have thought, huh? CRPS started in one limb in 78 patients, which was 88%, simultaneous start in 2 limbs in 10 patients, which was 11%, and simultaneous start in 4 limbs in 1 patient, which was 1%. The spread of CRPS from 1 limbs to 2. CRPS spread to another limb in 78 patients. Spread occurred simultaneously from 1 limb to 3 in 5 patients, and from 1 limb to 4 in 1 patient. CRPS spread from 1 to 2 limbs in 72 patients, and they did so according to the following patterns. Before we jump into that, the severity of CRPS symptoms in the second limb did not differ significantly from that of the first limb. There was contralateral pattern of spread in 53% of patients, ipsilateral pattern of spread in 32% of patients, and a diagonal pattern of spread in 15% of patients. New trauma preceded the onset of CRPS in a second limb in 37% of patients with contralateral spread, 44% of patients with ipsilateral spread, and 91% of patients with diagonal spread, indicating that diagonal spread is almost always associated with a new physical trauma. Patient characteristics did not differ across these 3 types of spread. Spontaneous versus separate trauma. In 38 patients who showed spontaneous spread of CRPS from a first limb to a second limb, contralateral spread occurred in 63% of them, ipsilateral spread occurred in 34% of them, and diagonal spread occurred in 3%, which was only 1 person. In the 34 patients who showed spread after a separate trauma of the second limb, contralateral spread occurred to 41%, ipsilateral spread occurred to 29%, and diagonal spread also occurred to 29%. Patterns of spread were significantly different between patients with spontaneous spread versus those who spread after a separate trauma. However, patient characteristics, including symptom severity, did not differ significantly between spread spontaneously and spread after a separate trauma. Patients with spontaneous spread showed a non-random pattern, so further analysis was performed on this subgroup. Characteristics of spontaneous spread. The median interval between the occurrence of the first and second limb was 21 months for contralateral spread, 19 months for ipsilateral spread, and 10 months for diagonal spread. The difference in intervals between contralateral and ipsilateral pattern wasn't significant. Compared to patients with a contralateral pattern with a reference value of 1.0, hazard of ipsilateral spread was 0.44, or diagonal spread was 0.04. The age of onset, sex, onset of symptoms in an arm or leg, or left or right-sided, did not affect the hazard. Compared to the presence of CRPS in 1 limb, the presence in 2 limb increased the hazard of spread to a third limb by 2.19, and CRPS in 3 limbs increased the hazard of spread to a fourth limb by 3.75. The hazard of spread in patients with onset of CRPS in the left side was 1.46 compared to patients with right-sided, indicating a somewhat higher risk of CRPS in patients with left-sided onset. Comparison of single versus multiple. 96 patients with single CRPS were compared to 89 patients with multiple CRPS. Patients with multiple CRPS had longer disease duration and were significantly younger at onset. Differences in disease duration showed that patients with multiple CRPS were 6.7 years younger. However, there was no significant difference in the types of trauma between the groups. Movement disorder was more common in those with multiple CRPS than in single CRPS, with a percentage of 78 to 54%. There was no difference between the groups found in the sensory symptoms. Patients with spontaneous spread had a shorter disease duration than those with secondary trauma-related spread, but there were no other differences between the 2 groups. The author's results show that CRPS usually affects 1 limb, but in some cases it spreads to another limbs, most often contralaterally at 53% or ipsilaterally at 32%, and usually without a secondary trauma. A diagonal pattern of spread, however, was almost always triggered by a new physical trauma. The mechanisms underlying spontaneous spread of CRPS to other limbs is unclear. Spread after a separate trauma followed no particular pattern, which strongly suggests CRPS in 1 limb doesn't specifically predispose a particular other limb to CRPS, and it supports the idea that these patients have multiple CRPS rather than CRPS of multiple limbs. Let's say that again because I think that's very important. This supports the idea that patients have multiple CRPS rather than CRPS of multiple limbs. In contrast, spontaneous spread to the contralateral limb was 2.3 times more likely than spread to the ipsilateral limb and 25 times more likely than diagonal spread. Patients with spontaneous onset or who have familial forms of CRPS develop the syndrome at a younger age and are more likely to have a more severe phenotype. Additionally, patients younger than 50 years old have an increased risk of having siblings with CRPS. In line with these studies, patients with multiple CRPS more often exhibited movement disorders and also had a significantly younger age of onset than patients with single CRPS. The dominant patterns of spontaneous spread observed here strongly suggest CRPS does not spread according to some systemic vulnerability, but is more likely to spread via spinally or cortically mediated mechanisms. Increasing evidence from experimental studies on neuropathic pain suggests that contralateral changes arise via altered spinal processing of incoming sensory information. In contrast to the number of studies on contralateral spread, data on mechanisms underlying the spread of symptoms on ipsilateral limbs are scarce. It is conceivable that glial-mediated changes at one segment of the spinal cord can reach remote segments by axonal transport via descending or ascending fiber tracts. Data suggests that ipsilateral changes are induced more easily than diagonal changes. Our study demonstrates that if CRPS develops spontaneously in more than one limb, there is a greater risk of spread to subsequent limbs without the requirement of a new trauma. This accelerated occurrence has been documented for clinical manifestations of other diseases and probably reflects changes in the central nervous system, perhaps in an attempt to adapt to the altered condition by remodeling of neuronal contacts and circuits, a process also known as neuronal plasticity. Some limitations. Interpretations of our results should consider some methodological issues and limitations. A retrospective design is less accurate than a prospective design and may result in incomplete data, although such issues seem unlikely to bias the results in one direction over another. Follow-up data were not available, and single CRPS patients had shorter disease duration than patients with multiple CRPS, which does raise the possibility that some single CRPS patients would have ultimately developed multiple CRPS if we left it longer to find out. We addressed this issue by controlling for disease duration in the analysis. As it is likely that major traumas are better recalled than minor ones, the frequency of minor trauma may be underestimated. One could argue that these patients may be incorrectly labeled as spontaneous spread. However, to address the objective of this study, we felt it was best to use a clear definition of trauma, soft tissue injury, fracture, or surgery, that does not include microtraumata. Notably, this study was performed in a tertiary center for movement disorders, which may lead to an overrepresentation of patients with severe or multiple CRPS. However, the objective of this study was to evaluate the spread of symptoms and not the prevalence of multifocal CRPS. As an aside, not related to this particular study, the number that I have seen for spread of patients when it's not at a specific center that deals with CRPS and movement disorders ranges from 30 to 40%, as opposed to the 48% that they have here. Finally, we are aware this is a descriptive study, and that the pathophysiological aspects we discussed have not been tested. In conclusion, this study shows that the spread of CRPS symptoms often occurs spontaneously, and contralateral spread is twice as likely as ipsilateral spread, but diagonal spread is rare. We contend that these patterns of spread implicate the spinal cord and/or supraspinal mechanisms, rather than systemic mechanisms, although further work is required to elucidate them in detail. Okay, and there is that paper for us today. Thank you very much for watching. If you'd like to check out this paper for yourself, see the notes that I've taken, or have access to the slides, that is going to be linked in the description. If you'd like to contribute to what I'm doing here financially, I have a Patreon and a PayPal. If you're in a good financial place, don't put yourself out if you're not. I have a website now, CRPS Contender. Still working on kind of really getting that up, but it is there if you want to check that out. Thank you very much, Emily Malcontent and W for Shep, for your continued support on Patreon. I really appreciate you guys. If you like what I'm doing here, please let YouTube know. Engage with my channel in some way, like, comment, or subscribe to help the algorithm get my content in front of other people who need to see it. Okay, I think that's everything. Thanks so much for watching. I hope you learned something today, and I hope to see you next time.